Out as a therapist, and then I moved into full-time crisis intervention. And for the next 4 years I did that. I covered the weekends, and that was back before ECOs. I don't know if you're familiar with ECOs, emergency custody orders, and TDOs is where they actually detain you to do a hearing. But at that time they didn't have ECOs, and so I covered Patrick County, Franklin County, City of Martinsville, and Henry County in crises by myself. And I could actually do it back then because the TDO didn't have a time limit, and they got a time limit on it now for ECOs. But anyway, I did that full-time 4 years, and so my experience with crises has been 4 years full-time, and then about 12 years as backup, available on rotation, those kinds of things with the agency in case they needed me. Certified to do pre-screenings in the state of Virginia. A little bit about my education. I got my bachelor's degree in behavioral science at Averett. It's university now. It used to be college, Averett University. And then I got my master's degree in clinical psychology from Radford University. So there's a little bit of background about me. I grew up in Ridgeway, currently live in Patrick County. I won't belabor myself any further than that. Let's start. Now, the way that I went about this the last time I did it, and I think it worked pretty well, is that assessing someone for suicide is like a puzzle. You gather all these pieces, and then you put the pieces together through an analytical process, and you come out with some sort of feeling about and an understanding of where this person is. You know, when you see somebody in crises like I did, I had to make a decision whether I let them go home or whether I send them to a hospital for observation and treatment. And if I send them to a hospital for observation and treatment, of course, there's a hearing that Virginia requires that a special justice conducts most of the time. A judge can do it, but they've got appointed justices here in this region that do hearings, and there's a doctor that's available to consult in that hearing. There's an attorney that represents the individual that's detained, and there's a mental health worker, a consultant, which I do for Southern Virginia Mental Health Institute, and then there's the individual. And we get together and discuss what this person has done, said, and then there's a decision made by the special justice as to whether they go to a hospital or whether they can leave. So in the process of doing that, your level of assessment will be the initial state of that assessment, of determining whether you think somebody else needs to be called, like our on-call crisis worker or somebody at our center gets involved in it at that level. And what you'll be doing in doing that, you'll be gathering all these different pieces, and if you know the right questions, you can get to that point very easily. It's not always easy to decide whether to let them go home or not, but you don't have to do that because you'll be on the telephone, and they'll be somewhere. We had a call the other day. This lady called and said she was feeling suicidal, and she was overwhelmed with her children and life in general. And she wouldn't tell us her address. So we couldn't do anything about it. We have no way in our agency to trace a call back. We don't have caller ID. You guys may, I don't know. That's really a good thing to have if you're talking to people on telephone is caller ID. But we didn't have that. So she said she would come to the agency, which she didn't. But we did have her telephone number, and we followed up the next day to make sure that she was okay, and she had stabilized by then, and she was just having a bad day and made some sort of irrational statements. So there's a process, and all of the things that hopefully I cover this morning will be pieces of that puzzle that you can, if you get this in your head, the pieces to look for, it makes it so much easier for you to determine how risky is this. What potential has this person got to harm themselves?
Do you find that people with places are more apt to do this than others?
The statistics say that if you have a mental illness, it increases your probability to harm yourself. Yes. Now that doesn't mean they will, but on a statistical basis, and a lot of this you're going to have to do on a statistical basis because you don't know the individual that's calling on the phone well enough to know their potential one way or the other. Everybody's unique in themselves, but if you take these data points that I'm going to share with you and you put them into your toolbox, and as you're going through talking to this person, you will know the right questions to ask to determine that. And part of what you will ask them is, have you ever been treated for a mental health problem? And if they're truthful, that's part of the data that you can gather that'll give you, and it's called a lethality check. And that means that you're going to talk to them about what their issues are, what their feelings are, who they are, where they're at, and in the process of doing that, you will come up with a conclusion as to how lethal is this person's statements. Or are they really going to harm themselves? And if so, what's my position in that? What can I do? Now, sometimes somebody will call like the lady called the other day and will not give you where they're at. Now, most everybody will do that. They'll tell you what their address is, or they'll tell you where they're calling from, those kinds of things. But occasionally you'll get somebody that will not do that, and that's troublesome when you do that. Let me just go through these data points, and if you've got questions, this is for you guys. If you've got questions, don't hesitate to ask.
Okay.
There's no bad question. I might give you a bad answer, but there are no bad questions. Let me share some facts with you. Suicide takes the life of nearly 30,000, and it's actually 32,000 something, Americans every year, and there are 500,000 attempts each year for suicide. Many who attempt suicide never seek professional care. So you'll get calls from folks that have never been seen by us, never talked to a psychiatrist, never had any exposure to a counselor. Their potential for improvement is good if they will grasp the possibilities that professionals can provide them. There are twice as many deaths due to suicide than HIV and AIDS. That's sort of shocking when I read that. Between 1952 and 1995, suicide in young adults nearly tripled. So there's a population that's growing in suicide, and why is that? We're not quite sure, but there's some speculations about different elements.
Growing?
It's still growing. 1/2 of all suicides occur in adults between the age of 25 and 65. There's a data bit. You've got an age range of high probability there. Men. And we'll talk about that a little more later on in this discussion. In the month prior to suicide, 75% of elderly persons had visited a physician. You got an elderly person on the phone, they're talking vaguely about suicide. Have you seen your physician lately? Yes, 2 weeks ago. That's a red flag. My point would be, okay, would you mind sharing with me why you saw your physician? Is there something really seriously going on with you? I have cancer. Another red flag. So some of these statistics, if you look behind them, logic will tell you, common sense will tell you, there's more to this picture than meets the eye just as the statistics. Why? And more than likely, they've got some bad news. They've got a terminal illness. You know, they're going to suffer excruciating pain for long periods of time. You know, the treatment's going to be real difficult, and so they consider their options. Although suicide is not a good option, it is an option that people sometimes start looking at. Suicide rates in the United States are the highest in spring. You ever thought about that? I always thought when I first started this, people probably kill themselves during the winter. It's, you know, if they don't do cold weather well, you know, all these different things. But if you look at the statistics and you follow the data, what happens is, and it's the same thing that happens to people that go to hospital. people that go to hospital, when they get out, a month or so after they get out, that's when they're high risk again. Because one, they've been under treatment for medications, it's elevated their mood some, but they're still struggling some with depression. And what happens is they finally got the energy enough to do something about it. When they're so down and so depressed, they don't have energy to do anything. So they don't actually attempt suicide at that point. Some people don't. But when they start getting energy and start feeling more energetic, then finally they muster the capacity to try to kill themselves. Sort of a strange turn of events there, but
Yeah.
that's what statistics bears out, and that's what it demonstrates to us.
That's when babies were conceived. That's what I've always heard.
Well, postpartum probably holds a piece in that, but I wouldn't think it'd have a significant alteration. This is generally through the whole population the case. For young people, 15 to 24 years of age, suicide is the third leading cause of death. You know, these statements just sort of stun you if you think about that. Suicide rates among the elderly is the highest for those who are divorced and widowed. So if you're talking to somebody on the phone and they're elderly, and we'll get into putting these pieces together a little bit better as we go along, and they just have been divorced or they're widowed, that's a red flag. And if you know to look at that, every one of these pieces that you see contributes to your assessment of where this person is on a probability scale, a lethality check scale, as to how dangerous they are just by who they are, not necessarily about what they're thinking right at that moment, but just what they carry with them in potential. And so as we go through these, store those away and hold on to that, because when you get somebody on the phone, this is going to be your roadmap, which direction you go, what questions you ask. And you need to know what questions to ask to get to the right conclusion. If they're elderly, there are certain questions asked. If they're young, there are certain questions asked. If they're female, there are certain questions asked. All of these things tell you. So at this point, statistics aren't just statistics, which I like, because usually I don't like statistics that much. But these are applied statistics. You can actually do something with this, and it gives you what to look for. And as a phone person talking to somebody, or even if you see them face to face, there's a certain amount of investigative work that you have to do in order to come to a conclusion. 80% of the people that seek treatment for depression are treated successfully. 80% that seek treatment. So there's a good indication that when you're talking to somebody, you can give them hope. You know, there's a great probability that if you'll seek professional help, you'll get a lot better. It's not like 20% only people, you know, and you're talking to says, well, you may get better if you, more than likely you will get better if you seek treatment. 15% of those who are clinically depressed die of suicide. Of those 15%, 90% had a diagnosable and treatable illness, such as major depression, bipolar disorder, some other mental illness, including schizophrenia, drug and alcohol abuse, post-traumatic stress disorder, personality disorders, especially borderlines. If you get somebody on the phone and they're real dramatic, you better watch out. They're more than likely a borderline personality disorder. And borderlines are the most difficult to help, the most inconsistent in following through what they say they'll do, and the most unpredictable of just about any population that you can deal with in mental health. So if you've got a borderline on the phone, it's going to take some doing to get to the bottom of it. There is an estimate of 8 to 10 attempts at suicide for one completion. Now, that one completion is too much. If you talk to 30 people and one of them kill themselves, that's too many. And so it gives us proportionally the number of unsuccessful attempts. So people don't do this real well. But the danger in not doing this well is that they can damage themselves. When I did crisis intervention, I would go to the hospital, and I've had people come in with all kinds of overdoses. I mean, it's hard to imagine what some people take to overdose. But when you come in to the hospital and you're on something like you've overdosed on Tylenol, they get busy. And it's not because Tylenol is lethal. Tylenol kills you inside. It destroys your liver. And you destroy your liver, your quality of life is going to diminish extremely. And so if they took an overdose of sedative medications, they can do something with that. You know, they can give them stimulants, epinephrine, something that will bring them out of it. But if you take Tylenol and you've had it in your system too long, there's nothing they can do about saving your liver. You're going to damage yourself permanently. You're not going to die. So then they're going to live. Not only are they depressed and dissatisfied with their life, but now they've got a physical malady that is going to encumber their ability to quality of life for the remainder of their life. So the damage that people can do in these failed attempts is a real issue that we need to be aware of, that even if a person attempts it and doesn't succeed, they can change their life in a negative way tremendously just by that. There are people going through critical care units all the time with overdoses. They put them in there to monitor them and make sure that they, you know, their vital signs are maintained because they take overdoses, but they're not successful. Highest rate of suicide is among men over 85 years of age. Another red flag. There's 65 people out of every 100,000. I don't know why I left the zeros off on every one of those, but that's just one of my things. Every 100,000 persons. 1 in 65,000 children aged 10 to 14 commit suicide. I saw a program on 60 Minutes, I believe it was, last night. They were talking about bullying. Did y'all see that? Good program. Good program. Now, when I was in Patrick County, I worked in the schools some with the troubled children in schools. And bullying is a real issue in school that I don't think the school system has fully addressed. And that's sort of the way it is with a whole lot of problems in society. We like to pretend that there's not a problem until we can't pretend that any longer. And then we've waited too long to get started on what we should have been working on a long time ago. But bullying was one of the major problems that we run into. Kids don't want to, you know, I'd get these children that didn't want to go to school. They're smart. They made good grades while they were there, but they just didn't want to go. And their parents couldn't figure out why they didn't want to go. And when we'd finally get to the bottom of it, somebody was bullying them. And out of that bullying, they get so desperate and so distraught that they consider suicide as a way out of that. So we need to be aware that you know, young people, you know, I think of youth as the real opportunity to enjoy yourself. You know, you don't have all the responsibilities of making a living, but to them, their world is very serious, and the bullying is very traumatic to them and drives them sometimes to do things that are irrational. Substance abuse is a risk factor for suicide, and you can probably understand why that would be. It alters your mental status. It impairs your impulse control. You know, it depresses you. If you're drinking alcohol and you're already depressed, you know, what's that going to be like? You're going to have more depression. The strongest risk factor for suicide is depression, and that's sort of a given. By 2010, depression will be the #1 disability in the world.
So did that happen?
I would think it did. And especially in this area, when people's unemployment increases, when their livelihood is discontinued, when they feel destitute. You know, I see people every day that are losing their house, they're losing their cars, they don't have any income. You know, that really drives depression, situational depression. If you're predisposed to depression anyway, and you've got all those situations going, that just exacerbates your depression in the circumstance. Suicide is the eighth leading cause of death in the United States, and homicide is the 15th. Now that's a startling statistic as well. You know, I always thought that more people killed each other than people killed themselves, but that's not true. It's twice as many people kill themselves as people kill other people. It accounts for 1% of all deaths. All deaths. That's a lot of deaths. Suicide is the third leading cause of death in 15 to 24-year-olds. You can see a trend over the years of increase in children and adolescents and all this stuff. And it makes you wonder, what is that all about? You know, the economy of our country is declining across the whole country. Everybody's struggling. Businesses are closing down. I had this young lady that I used to, before I went to the agency, I worked at a residential program for troubled juveniles. And had this young lady that she was from a middle class, upper middle class family. Her father was a higher management in a factory setting. Lost his job. All of a sudden, she doesn't have the designer jeans and the name brand shoes and all this stuff. And her world collapsed. You know, the people that she buddied with no longer associated her because she wasn't in the clique. She didn't wear the stuff. And you know what she did? She took a .357 Magnum pistol and stuck it to her chest and shot herself. It went all the way through her. Just because she was depressed and upset about the fact that her life had changed and that she was wrapped up in the fact that material was what made who she was. She found out different later, but she's got this terrible scar where the bullet came out on her back and the trauma of doing that. So, you know, what one person sees as important is not necessarily what I would see as important or what you would see as important. But what you have to try to do is get inside their world and see it from their perspective and understand what impact that might have on them. It's easy for us to stand back and look at that and say, well, you know, why in the world would she do that? But to her, that was her world. That's all that she knew. You know, at 14 years of age, you don't have a lot of experience. So you base your decisions on what you know right at that particular time.
Everything else.
But gladly, we do learn, and some of us learn the hard way. Most of us do it, as a matter of fact. But, you know, we need to be alerted to the fact that these young people are struggling with issues that may not seem to be desperate issues to us, but to them, it's their life. It's their whole being. Now, genetics plays a part in all this. A lot of times when you're talking to somebody, and here's another question for you. If you're talking to somebody and they're indicating that they're feeling suicidal, one of the questions is, have you ever had a family member to commit suicide? Fairly simple question, and you know, a lot of times they say, yes, my father killed himself. This lady called the other day. One of the questions posed to her is, has anybody in your family ever killed themselves? Guess what the answer was? My mother and father. Now, what does that do to your evaluation? Both of them killed themselves within 6 months apart. So if you know that that's one of the issues you need to look at, put that in your list of conversational pieces, and you can weave it into your conversation. You don't have to be blatantly obvious about what you're doing. Most folks don't follow what you're doing. They just respond to what you're asking them. It's surprising at the questions that you can ask if you time it right and you pose it in the right framework. People will tell you about anything, especially if they're struggling, except for their address. They don't want you to know that because they're afraid you're going to send somebody after them. 30 to 40% of people who complete suicide have made previous attempts. Another red flag. Have you ever done that before? Yeah, 2 years ago I cut my wrist. More danger. There's an indication that you need to really pay attention to what they're saying. So these folks are at higher risk. Risk of completed suicides is more than 100 times greater than the average in the first year after an attempt. So that's another piece that you can add on to that, is that they're at great risk. 80 times greater for women, 200 times greater for people over 45, 300 times greater for white men over 65. So there's a lot in that sentence that gives you indication. Did I give y'all a handout? I did, didn't I? Okay. Read over that again, because I know you won't get all this first time through. But if you're talking to somebody and you start looking, and okay, one of their parents killed themselves. They tried 2 years ago to kill themselves. You're getting closer and closer to understanding what this person is all about, in the sense of how dangerous are they right now to themselves, and what is the probability. Males, and we mentioned this a while ago, 5 times more likely to die by suicide than females. So if you've got a man on the phone, he's 65 years of age, his wife just killed herself 3 months ago, what does that say to you? He's dangerous. He's scary. You need to find out where he is as best you can. Beg him to come in and see you. Do something. Send him to us. We'll talk to him. But he needs somebody to lay eyes on him, because he is at tremendous risk. Precipitating events that distress a person is loss of love, loss of a loved one, career change, can change the individual's approach to life. Some people work, and work is what they are. And I don't know whether that's unfortunate or I'm sure for the employer it's great, because they got a person that this is what they live to do. Now, most of us have hobbies and other interests and those kinds of things. And my dad used to say, don't put all your eggs in one basket. Yeah. Don't put all your life eggs in one place. Scatter them out a little bit, so that if one piece falls apart, you still got your life, and you don't have your identity tied up in what you do. I think it's real dangerous to become what you do as a living. Like I do what I do, but I am not just the liaison for Piedmont Community Services with local and private hospitals. I've got other things outside of that gives meaning to my life. And if I lost my job, I wouldn't be happy about it, but it wouldn't be the end of the world. Suicide attempt is a clear indication that something is gravely wrong in the person's life. Of course, we knew that. If you're talking to them on the phone, you're at somewhat of a disadvantage, because a lot of the stuff that I get from people when I see them is body language, just their inflections of their speech, their movements, all kinds of things that I pick up just by being in their presence that you guys won't get to do. But here are some observations that you can look for and maybe pick up over the telephone. An unrelenting low mood, pessimism, hopelessness, desperation, anxiety, psychic pain or inattention, withdrawal. And you can pick that up in people's voices, some of these things. The hopelessness, the desperation, the pessimism. They'll tell you if they're anxious. They can't sleep. They can't eat. It just goes on and on. Withdrawn. You ask them a question and they give you monosyllabic answers. Yes. No. What I usually do is press them a little bit. And I'll sort of go around to the side and see if I can get them to say more about it. A lot of time it's just getting them to talk. If I can get them to talk, then I can get them to tell me something. If I can't engage them, if they won't engage me enough to converse with me, it's awful hard to find out what's going on with them. But most folks, if you show an interest in them, they'll talk to you. Impulsivity, giving away possessions, unexpected rage and angry outbursts, unexpected change in demeanor, Their hygiene goes down. They might have bruises or cuts. You won't get to see those on a phone conversation, but as a full assessment, I get to actually look at them and see what they're all about. There are some thought processes that you need to red flag too. If the person is having command hallucinations, do you know what that is? Schizophrenics have those. People with psychotic disorders per se could have those. It's when they hear voices telling them to do things. Now, it may be telling them to love the whole world and, everybody's all right. That's not a tremendously dangerous issue. It might distort their behavior to where people are getting concerned because they're walking down the street hugging strangers. It may be a little bit concerned, especially in some parts of the country. Probably not around here. But if the command voices, which is God, I've had, like I say, I've seen a lot of people in crises, and God is one of the central focuses of these command hallucinations. I mean, how else would you rationalize it if you hear a voice telling you to do something? It had to be God. I mean, there's nobody else standing there. Mm-hmm. And God can speak to you, according to religious beliefs and actually say things to you. Well, a lot of these people attribute it to God. God's telling them to go out and kill, a certain population. I met a guy one time, he was running down the middle of 220, barefooted, t-shirt, jeans, dead of the winter, blowing snow in the air. Dual-lane highway, running down the center line. Semi-trucks are coming by there, and seeing this guy is nighttime. Lock the wheels up and slide by him, and finally somebody called the police and they came and picked him up. Nice guy. And I went and talked to him and I said, what are you doing? He said, well, God has told me to gather up all the blue-eyed, blonde-haired women in the world, and we're going to go have a big party, and then God's going to take us all to heaven. I said, okay. He said, I believe He'll let you go too if you want to. I guess I had blue eyes. I was partly qualified. And I said, well, I'm not so sure. I said, it sounds like that's an awful big undertaking. Would you like some help with that? He said, yeah. So I sent him down to Southern Virginia in Danville, and they helped him with it. But the command hallucinations that he was having was telling him to do something that put him in imminent danger. So it allows the state to help him right at that point because he probably wouldn't be able to help himself. It was obvious that he couldn't. So when somebody says, I'm hearing voices, first thing I say is, well, what are they saying to you? Can you tell what they're saying? Some people say, oh, I don't know. They're just mumbling. I can't make it out. Okay. I can leave that alone for a while. I don't have to pursue that too much. But if they tell me, yeah, I can hear them. And I said, exactly what are they saying? They say, oh, they say bad things. Well, that's not enough. That doesn't satisfy me. Bad things could be that you're a terrible person, or that you're deplorable, or you're useless, or all that. But and that's a concern if they're doing that, because over a long period of time they wear the person down to where they get real depressed and they may think of suicide. But if the voice is saying you're no good and you need to kill yourself, that's a fairly imminent indication that they may. And then I said, well, do you know that those aren't real? And they'll look at it and say, oh, no. I can hear them. They're there. Okay, I'm going to do something about that. I've got to involve myself in that because they're likely reality testing is poor at that point. They can't tell real from not real, and the voices are telling them something that's harmful. Something needs to be done about it. So as you're talking to people, you need to take into account. The next one is delusional thinking. I had a guy I used to talk to, and he was sort of unique in the fact that most people's delusions are what they call fixed delusions. They don't change a lot. I knew this woman thought she was God, and she continued to think she was God. Now you could treat her and that would get better and she wouldn't talk as much about that. But as soon as she started to decompensate again, she'd go right back to that same delusion, and it was the same process over and over again. But this guy was different. His would change every now and then, just randomly change. And he came up to me one time And he said, I own a lingerie factory in France, and I need a CEO, and would you like a job? And I told him I appreciated it, but I already had a job, and I was pretty satisfied here, and I couldn't speak French, so I probably didn't want to do that. Occasionally, I try to do what they call reality testing, and so, well, you know that's just in your head. And if you know the individual, you've got to be careful. If you know the individual, you can do some of that. And if they trust you, they'll sort of recheck their thinking. They'll sort of look and say, really? No, it's not real. It's in your head. When these voices talk to you, I don't hear them. You know, they don't talk to me. They're not real. There's something going on in your brain. And a lot of times they just sort of look at you sort of puzzled, like, well, that's just hard to believe. But then they'll say, well, maybe it is. And that kind of thing. And then next time you see them, they're right back into the delusion again, unless the medication helps, which is a way of treating those kinds of things that seems to be of help to some people. But anyway, the delusional thinking can be dangerous too. Had this person that God told them, according to them, to strip off all their clothes and run down the middle of the road in pouring rain. Now, when it's raining, you can't see very well out of your automobile. So you probably shouldn't be anywhere close to the road when it's raining to begin with, let alone running down the middle of the road in the pouring rain naked. It's an unhealthy thing to do, so we had to try to help that person get some treatment for that because the delusions were leading them into a way that is dangerous. But you have some delusions that aren't dangerous, and they're not repaired evidently by medication, that don't present in a way that the person needs to go to the hospital. It's not telling them to hurt themselves or put themselves in a hurtful position, so you can sort of live with some of that. But if it leads them to harm themselves in some way. Same thing with obsessions, when a person just mentally gets stuck. Now, I've had people obsessed about medications being poison. This stuff is killing me. It's poison. I can't take it. Well, when they don't take their medication, then they decompensate to a level that they get dangerous. So that obsession with the medication it's both delusional and obsessive. When the medication's poison, and I mean they were sincere about the fact that the medication was killing them, and it probably, because of their mental status toward it, was having a reaction on them in the sense that sometimes what we tell ourselves is what really sort of our body mimics if we're not careful. But you need to take into account that if they're obsessive about something. I had a guy that he was obsessive about his divorced wife, and she was seeing other men, and he was just obsessed with the fact that she couldn't do that. She was his wife. Now, it's a good likelihood he's going to get in trouble with that, because that's going to lead him to intervene with these men that are seeing his wife. And when you do that kind of thing, sometimes people have drastic reactions to it. So he could get hurt seriously by doing that. So let's talk a little bit about preventing suicide. Now, if you're taking all these things into account, you're building up quite a picture of the different elements that lead into different populations as far as suicide issues. And how to put that together is an analytical process, and my mind is analytical. I'm stuck with it. I've spent a lot of years trying to get over into the intuitive side, and that's a challenge. So I use data as a basis for most of my decisions. And it's a funny thing, me and another guy did crises at the same time. He started work the same day I did with the agency. We both went into crises and did it 4 years together. And his approach is very intuitive. It's not really overtly factual driven. I'm sure there's some facts back in his head and different things that guide him to some degree. But if you watched him work, he's basically feeling based, what feels right, what do you think is going to happen here, that kind of thing. And I'm analytical based, so mine is basically gathering facts like, a police investigator or somebody that does those kinds of things. But the funny thing about it is both of us did the job, and I think both of us did a good job, but we did it in a strikingly different way. So this is not something that's hard science. It's something that you have to develop a feel for according to your own mental operations. And you can use the data and you can learn things, and that will guide you. Practice and talking to people will be helpful to you, because experience is the way that you develop the manner of interviewing people. When I see somebody in crises, basically I let them talk. And I'm aware of what I need to know, so I'll let them talk, and when they hit on something that I need to know more about, I show an interest there. And I say, could you back up and tell me a little bit more about this? And they're glad to do it. I mean, people want to talk to you, usually, unless they're just giving up altogether. Usually you can engage somebody and get them to tell you their story, because nobody else wants to listen to it. I've had people tell me, I'm just so glad that you came to talk to me, because nobody else will listen to me. Listening is as much a part of this as giving the answer. They're not always looking for the answer. They're looking to tell somebody their story because nobody listens to them. So encourage them to tell you their story. What's going on, and just have these in your mind, these elements that you need to check. Some of them, as soon as you speak to them, you'll have some of it answered. Young voice sometimes gives you an indication of youth or elderly. The voice changes as you age. Sometimes you can actually tell race or those kinds of things by the voice, which is an indicator as to how lethal or non-lethal or dangerous this person might be as a statistical norm. So when you talk to people, you need to put all these pieces together and have them ready in your mind to insert in the conversation, and then you can get what you need. And they're not even aware that you're searching for anything. They think you're interested in them just because you're interested in them. And part of that's true, because you want to help them. But the other part is you need to know something about this. You really need to understand it. So, all these issues carry with them some indications. And there's medications that are very effective out now called serotonin reuptake inhibitors, SSRIs. And that's one of the modes of treating people that are extremely depressed, which is the high-risk population in suicide, and is effective with these folks. That and cognitive or cognitive behavioral therapy. And in describing cognitive behavioral therapy in a short way is that, okay, what you do and what you think has a lot to do with how you feel. It's just that simple. Now, we can write theories to cover a whole book on this, but the basic essence of that is that if you walk around telling yourself terrible things all day, you're going to feel terrible. You're really going to feel that way. If you're behaviorally oriented, which I used to see people in therapy, and the first thing I wanted to determine is, are they cognitive oriented or are they behavioral oriented? If they're behavioral oriented, the conversation I talk to them about is, what have you been doing? And what kind of consequences did that bring to your life? Was it negative or positive? If they're cognitive oriented, which is more mental side of it, what have you been thinking? And how is your thinking affecting your well-being? So these are things that you need to bear in mind. Now, okay, if you had two callers on the phone, one of them is a 65-year-old white male, and the other is a 35-year-old black female. Which one's the highest risk? Just for that information. You both agree? There you go. Statistically, the 65-year-old is at tremendously higher risk than the black 35-year-old female. One, if you look at statistics, whites have a higher rate of suicide than any other population. Asians don't kill themselves as much as white people. Black, Afro-Americans don't do that. Mexicans are actually at the bottom of the suicide scale.
Is that cultural?
Yeah, that's cultural. Native Americans per 100,000 kill themselves more than anybody else, but per population in a general sense, there are more white people, of course, and there are more white suicides. And males are in the top echelon of those white people that kill themselves. Although per 100,000 Native Americans kill themselves, and we can understand that if you've ever been on a reservation. It's pretty destitute circumstances. So if you have somebody to call, the first thing you can look is, okay, how old are you? Can you determine what their race is? Can you determine what their gender is? Has anybody in your family ever killed themselves before? Have you ever struggled with depression or been treated anywhere and gotten any counseling? And it just keeps clicking down through there what you need to know. And every one of those issues, either you roll them in or roll them out, gives you a picture of this person as far as how high is the probability that they will harm themselves. I ran over, didn't I? I told you I could talk about this for days. So these pieces of paper I gave you aren't just pieces of paper. They're tools. And if you take those tools and analyze them, put them in your brain, and I can't get them in there this morning. I mean, you'll have to look over them and ruminate about them and think about it and push yourself to acquire this. But every time you talk to somebody on the phone and they say something about suicide, you'll probably be driven back to go look at this and say, I needed to ask that, I should have done this. You know, that's the learning process, is the fact that if you know where there's some information that could make you better at interviewing a person and coming to a determination, that will be the driver that makes you a good interviewer on contact about somebody that calls and mentions suicide.
You know, being a contact, we're going to have to be both intuitive and analytical.
I think you're driven to that.
It's not going to be just one, it's going to be both.
And I don't deny either one of those, although I'm on one side more than the other. I have spent years trying to understand intuitive thinking and have gotten to a point that I do some of that and trust it, but it's been a long journey. It's been a long journey. But it works. It works. And to be balanced in that is the best that you can be. But if you have the elements to start with, you've got to have the information to be intuitive. I mean, some information, where it's just talking to them and you know, you pick up on their hostility, that's an indicator that they may be serious about what they're doing. If they're and drinking alcohol, and a white male, and have access to guns, you've got the highest risk person that you could actually talk to. And that's all in your reinforcements, you know, because this guy's really on the edge. If we don't do something, it's probably our last chance. So those are the things when I went into crisis that I wanted to know. I didn't guess whether I was asking the right questions, whether I was looking at the right things. I wanted to know that these are things I need to know. And then I can make a good decision. And I can defend the decision. But if I don't know that, I'm guessing. You know, I can't intuit about something I don't know anything about. Hope your work at Contact is fulfilling to you. I'm sure it will be. And you've been a good group.